So, good evening, my fellow doctors and dear participants. I pray each and every one is in good health. Time does fly, knowing we have arrived in this 10th episode of ASEAN's Head&Neck webinar already. This webinar started because we couldn't continue our Asian Head&Neck dissection course in Khon Kaen, Thailand. If I may go back a little, this program was founded by Professor Alfredo, Dr. Patrafoot, and myself, with COVID-19 and head and neck cancer as the first topics. Later on, Professor Muhammad Razif and Professor Christopher Goh joined our network. The circle of five, which I like to address the five of us, keeps the excitement and collaborations going up until now. The 10th episode, not forgetting to add a trademark in each episode. Could you guess what is the trademark is? Music. Luckily for the five of us, since we find music essential in our lives, we decided to include singing from us and our fellow head and neck surgeons across Asia. Before I hand the mic to the moderator, Professor Razif, I would like to take a moment appreciating each of keynote speakers, panelists, doctors, participants in this program. Hopefully, tonight's program would benefit our knowledge, network, and purpose as practitioners and learners. Living in this pandemic does not stop us in creating something. I believe it challenges us to do more than we have done before, or preserving what is already good. Thank you. Enjoy the webinar. Thank you. And then I give to the moderator, Professor Razif.
Thank you. Thank you very much, Professor Marlinda, our dear friend. It's always good to see you and hear from you. Ladies and gentlemen, as mentioned by Professor Marlinda, this is our 10th episode of ASEAN Head&Neck webinar. And this time, we have an exciting topic of Occult primary. It's also known as carcinoma of Adham primary. We're going to have a line of experienced speakers, panelists. We have Professor Subhaschandra Shetty from New Zealand. Welcome, Professor Shetty. We know it's past midnight in New Zealand, so it's good to have you here at these hours. We have Professor Melvin Chua from Singapore, and our panelists, Dr. Thanuja from Malaysia, Dr. Napadon from Thailand, and Professor Christy Joy from the Philippines. We have a pre-lecture poll. If you can have over here the pre-lecture poll. So ladies and gentlemen, you can see from your screen, there is a question there, the pre-lecture poll. You can scroll up and down and you can answer the questions. Then we will discuss this after the panel discussion session. Okay, if you can scroll, there's a question 1 and you have a question 2. Okay. So, all right. So now, with a great pleasure, I would like to introduce our first speaker, Professor Subhaschandra Shetty, all the way from New Zealand. He is a consultant otolaryngologist and head-and-neck surgeon. He worked as a deputy clinical director at the Northland District Health Board Hospital in New Zealand and honorary senior lecturer at the University of Auckland in New Zealand. So without further ado, I'll pass the mic to Professor Shetty. The floor is yours. Thank you.
Can I share the screen, Professor Razif? Can you let me?
Yep. Okay.
Yeah. First of all, thank you very much for inviting me to this such a good academic program you're all having. I thank Dr. Patrawood, Dr. Alfredo, Dr. Melinda, Dr. Mohammed Razif, and Christopher Go, and also my panelists, Dr. Thanuja, Napadon, Christine, and my co-speaker, Dr. Michael Chua. Thank you from down under, New Zealand. And my talk is on surgical perspectives from New Zealand. I'm a head and neck surgeon in a part of the corner of the globe where you guys are having a central podium here. We are in down under here. Currently we have just are in lockdown actually. This was the third lockdown since last 2 days. So I was lucky that I could see only head and neck cancer patients, and rest of the rhinology, otology, everybody's clinics were canceled. And we are here, top part of the top North Island, and we do have quite a lot of indigenous population who also suffers from health disparity and head and neck cancer. Now, it's very interesting. The talk is on carcinoma, that is a metastatic deposit found in a patient's neck, and we cannot identify the primary anywhere in the head and neck. Once we have gone through our thorough clinical examination and clinical investigation. And this is, it's not a routine circumstances. It is quite rare. However, it does happen very often, and we need to know the basics of how to treat this. And I think it is like search and rescue. We need to search for the primary, where it is coming from, and then we have to rescue the patient from the disease what he has. So my responsibility is for search and part of the rescue, and my co-speaker, Dr. Michael Chua, will tell you all the knacks about how to rescue these patients. But why are we discussing this right now? Because this problem is there in ENT since last 70 years. At least the literature is amassed quite a lot of content in the last 70 years. And we go through some of the historical concepts about how to assess these patients. And also, by respecting the history, how do we go ahead with the current knowledge? Historically, we did take a good history and thorough examination. And the examination included general abdomen and lymph nodes. And we did have CTs and chest x-rays. And also we knew that certain basins of the neck drained from certain primary area, and we could manage zeroing on those. However, we are looking at unknown primary here. So extrapolating from the older knowledge of level 1 to level 2, level 3, level 4, level 5, we could guide our triple endoscopy or pan endoscopy and blind biopsies, mainly of tonsils, base of the tongue, nasopharynx, rather curating the nasopharynx, and sometimes taking biopsies from the piriform fossa. This was our routine workup, and also get a CT scan. But current situation has changed. Why we have to address this now more interestingly and more thoroughly than before? Because as you know, majority of the carcinoma unknown primary, we call it as CUP. Dr. Mohammed Razif called it as CUP, So I'll follow the trend. And it arises from the primary in the oropharynx. And majority of the cup are HPV mediated currently, majority. And majority of the cups can be converted into a primary, non-primary. Even though it acted as an unknown primary, we can change it to a known primary. And also our knowledge on HPV-related metastases and HPV-related oropharyngeal cancers have gone up. And this picture suggests in men, oropharyngeal cancers have gone up. And also in white population, it's gone up. And the rest of the population's gone down rather. And in mixed anywhere you see oropharyngeal cancers are mainly caused by HPV nowadays in at least Western literature. This could be not true for some of the population who are engaged in heavy smoking, and traditional carcinogens are still working on our oropharynx. This is almost 5% of all head and neck cancers, and 50 to 80% of palatine and base of the tongue cancers present with unknown primaries sometime, or unknown primaries have got, metastases have got primaries in this area. And some reasons for not able to detect them are small primary tumors. They are very slow growing and very small, and sometimes those primaries involute, and that's why they don't express themselves. Classically, painless enlarging neck mass and a single node in 50% of the time, very rarely bilateral presentations without primary. Usually males outnumber the females, 5th and 6th decade, and a lot of risk factors which is present. You can see that in my slide here. And what do? We take a good history through head and neck examination, including palpation of the tonsils and base of the tongue. I tell my fellows and registrars, without the palpation of these, your examination is incomplete, because sometimes the tonsil may look normal, but palpation, it could feel hard. And then that will clinch the diagnosis. This is coming from tonsil, even though that's looking normal on a CT, MRI, or any other modality. Then we undertake a good endoscopic examination, nasopharynx, oropharynx, larynx, and hypopharynx, and document these areas. And also consider other primaries, because we have not needled it yet. We don't know the histology yet before we say it is a carcinoma unknown primary. So consider other examination, like cutaneous examination for melanoma, very, very true in New Zealand. Thyroid malignancies can present as unknown primary, nasopharyngeal cancers, hematological cancers like lymphomas and chronic myeloid leukemias, thoracic malignancies, abdominal malignancies, and pelvic primaries, especially if you have a left-sided supraclavicular mass. And that's also can be a metastasis with unknown primary. Now, with the recent development of narrowband imaging by Olympus endoscopy systems, we can look into some of the areas and target our biopsies. Narrowband imaging is nothing but the white light passing through a filter, where it filters other light, allows the only blue and green wavelengths, which hits the mucosa and allows us to look at the vascularization, especially neoangiogenesis. So the white light hits like this, but NBI image, when the NBI switches on, after the color adjustments, gives you a different image, which may suggest in recruitment of new vessels and identify unknown primary to a known primary. its sensitivity is high, specificity is especially high, and I use this every day in my head and neck cancer patients, whether they are known primaries or unknown primaries, because it's a nice modality to be familiar with. Cytology is a cornerstone of the diagnosis, and it can give you a very good understanding, and also allows you to do a lot of immunohistochemistry work, especially using ultrasound. It improves the yield. Yeah, especially if they are cystic nodes, you can needle the wall where the viable cells are still present. Core biopsies are slightly controversial. However, if it is a large mass and the FNA is not giving you any idea, core biopsy can be pursued. However, literature warns you that if you do core biopsy, you spill the tumor in the neck and you should be prepared for neck dissection. I don't know how much true this is. The FNA samples can be immunohistochemistry stained for P16, which is a surrogate indicator for HPV-related oropharyngeal cancers. And EBV encoded RNA can be in situ hybridized with the FNA and directing us towards the nasopharyngeal malignancy. I also send a needle washout thyroglobulin for every neck lump where I cannot find a primary tumor on my initial examination to rule out papillary thyroid carcinoma. Now, some of my recommendations come from ASCO's and our own personal experience and our unit experience, head and neck unit in Auckland, which is a large unit. We see quite a lot of patients every week, at least 12 to 15 new patients in a multidisciplinary setting. All patients should have a CT scan, but I will go further with the PET scan if it's available. It assesses the adenopathy, secondary primary metastasis in the lung. So it shows evidence of primary site. However, it is infrequently of significant value in diagnosing low volume tumors. If the tumor is itself coming out in your cross-sectional imaging, you should take that patient's name off the carcinoma unknown primary list. If the level 2 and 3 nodes are enlarged, we consider MRI as well, which is a beautiful modality for tongue-based lingual tonsil, lingual angle, and also the skull base and cranial nerves for perineural spread. PET-CT has been our cornerstone in assessing nowadays. It's a standard of practice in New Zealand to get a PET scan when you have a level 2, level 3 node, which you don't find a primary in your clinical examination. However, there are significant false positives, and I'll go through that in some of the examples. For example, this particular gentleman had presented with the neck node. As you see, there's a large node here. I took a needle sample and I subjected him for FNA. After the needle sample came as P16 positive metastasis, and the PET scan spectacularly failed to identify the primary. However, clinical assessment while I'm doing a panendoscopy, the tumor was peeping through the superior pole of the left tonsil, as you see here. Tongue base was almost normal, and we could see a large vessels in the tongue base, so I kept myself away from it, and we did the biopsy here. So the under anesthesia is also very, very useful. Now, we do subject the patient for endoscopy under general anesthetic, and then we take the tonsil off for ipsilateral metastatic node. This is definitely a kind of tonsillectomy and subjecting the patient for frozen section. And then when the frozen is confirmed tumor, we go for a lateral oropharyngectomy. If it is the carcinoma in the tonsil itself, to get a negative margin. And as you see here, this is the tonsil. Even though it was a PET negative, patient underwent, we went ahead and did a biopsy of this area, frozen positive. Then we did a oropharyngectomy with superior constrictor as our lateral margin, and also ipsilateral mucosectomy of the tongue base. And subsequently, after this, we went ahead and did a level 2 to level 4 node dissection. And we poured TCL onto this area and it healed beautifully. This particular patient presented with the neck node, which was a P16 positive again, metastatic node, searched everywhere, and did a PET scan, did not reveal any primaries with the examination, then underwent mucosectomy and tonsillectomy. And the tongue-based mucosectomy specimen showed a small T1 lesion of 4 millimeter in the crypt primary. So these are all very, very possible when you do a thorough discovery or search, we call it as, where a simple evaluation under anesthesia gives you only 30%, almost 30%. Evaluation of the head and neck under anesthesia with the ipsilateral tonsillectomy gives up to 50%, and evaluation of head and neck under anesthesia with microlaryngoscopy and biopsy or excision of the suspicious area, the primary detection rate goes up from 25 to almost 90% in the literature. Now, we bring in robot into the discussion. Unfortunately, I do not have robot in the public setting in New Zealand, but there are a lot of robots in the private setting. And transoral robot and transoral laser microsurgery has increased our detection rate of the primary from 78 up to 94%. So, as I mentioned, unknown primary is not unknown primary. We can convert it into known primary in majority of the cases. However, all these procedures have got its own risks, its own complications, which should be discussed with the patient in advance. So, Dr. Chua will go through ASCO guidelines again, but I'll go through some aspect of it as a suspicion neck mass comes with history, physical examination, fine needle, HPV testing, EBV testing, as I mentioned, CT scan, no primary detected, a PET CT. This particular thing depends on the resource, what you have. My MCQ says that CT scan or a PET scan, but we usually go for CT scan in many countries. However, if your resource is there and a standard of practice is PET scan in your institution, we should go ahead with the PET scan rather than waste time or double radiate the patient. Now, when we can't see a primary, a random biopsy should not be done in this era. So you have to complete operative aerodigestive examination under microscope, under endoscopy, and a at-risk mucosal site needs to be seen, and also a PET-directed or a NBI-directed biopsy should be done. And if it is a unilateral neck mass, ipsilateral palatine tonsil, frozen, no primary identified, a lingual mucosectomy can be done. And if there are no primary still not identified, we will go further and knock the doors of Dr. Michael Chua so he can treat the patient. If it is bilateral lymphadenopathy, we again go through this. A contralateral lingual mucosectomy and contralateral tonsillectomy has to be considered in a bilateral lymphadenopathy settings. Bilateral lymphadenopathy happens when there is a tumor in the tongue base, nasopharynx, supraglottis, or subglottis. And also oral cavity. Of course, oral cavity examination is significantly must. Then as a surgeon, how do I rescue these patients? It's very important. The prognosis of these patients depend on HPV. As you all know, HPV cancers do very well. Also age, and what is the nodal state? It's a single node, multiple node, or any clinical signs of extranodal extension, and P53 status as well. We don't really bother about that much anyway. Some of the issues to consider is when you do oropharyngeal biopsies, try to get a negative margin. A positive margin in an oropharyngeal resection can lead to chemotherapy. And PNI and LVI is also very important histological issues to consider. De-escalation is a big strategy, as you all know. Surgical morbidity is quite high. We deal with the patients, but we also give complications to the patients, especially tongue-based resection can cause significant hemorrhage. Tonsillectomy can cause significant fibrosis and also risk of hemorrhage and risk of injury to the other areas. We should consider radiation effects and chemo effects, which are quite heavy. Radiation effects, especially osteoidal necrosis, dysphagia, and xerostomia, and taste and quality of life is really, really significant on these patients. ASCO has a significant good write-up, and I encourage everybody to read this beautiful document headed by Ellie Magami. It's quite nice to read and disseminate, and also teach our residents what is the way of treating these things in the 22nd century. Quite a few other articles. However, there are two broad approaches: primary surgery, which I'm focusing on with neck dissection, plus or minus RT and chemoradiotherapy, and I'm sure Dr. Chua will deal with this. And some institutions do primary radiotherapy, and some institutions do some primary surgery. We are heavily on surgery. Not that our radiologists are weak; they are fantastic people. We work together with them in a multidisciplinary setting, and if there is a clinical or radiological signs of extranodal extension, we don't deal with them with the surgery. We straight away RT and chemo. Surgery doesn't have much support in these settings. It's all extrapolated from non-HPV cancers. However, selective neck dissection seems to be the best way to go. And if you find intraoperative extranodal fixation, then a modified radical neck dissection has to be done. 5-year overall survival favors the addition of surgery in this setting, and also 5-year disease-free survival trended towards addition of surgery. So surgeons are still have some business to do in these cases. And if you look at the literature, it favors radiation plus surgery. When this forest plot, everything towards the positive side here favors surgery plus radiation therapy. So hardly anything sits on the other side of radiotherapy alone. Ipsilateral or bilateral, I'm sure Dr. Michael Chua will deal with this. So this particular slide, again, ASCO guidelines saying what do we do with the treatment-wise. As I mentioned to you, neck dissection and primary surgery to extirpate the suspected areas is a good idea, especially tongue base and tonsil in this era of HPV. Now, we should not forget, it's not only SCC causes unknown primary. Rarely we do get adenocarcinomas as a metastatic tumors. And these are very, very interesting. And the search becomes quite wide, like somebody missing in a southern part of the New Zealand, where inhabitable population is very, very less, and people do go missing when they go hiking. And there's a huge amount of search goes on. And that's how that search for adenocarcinomas, it's a whole body search. And we need to be, as a head and neck surgeons, we should assist in getting a primary detected for adenocarcinomas. It's quite interesting area where immunohistochemistry plays a very important role. Thank you. I hope I have covered some of the aspects here. This is the beach next to our house. You're all welcome to join us when the COVID travel opens. Thank you.
Thank you very much, Professor Shetty, for a very informative, very exciting, and we definitely will learn a lot from your talk. Before I proceed, there is a few questions already there, but if possible, for the participant, if you can type your question in Q&A box, we will address the question later. So thanks again, Professor Shetty. So I would like now to introduce our second speaker, Professor Melvin Chua from Singapore. He's a clinician scientist from the National Cancer Center, Singapore. He's a principal investigator, Tangjaturonrasme Laboratory of Optical Imaging, Photodynamic and Proton Beam Therapy Precision Radiation Oncology Program. He's a head and senior consultant, Head and Neck and Thoracic Center. So, Professor Melvin Chua, the floor is yours.
Thank you. Thank you so much. So while I'm sharing my screen, I think I'll really like to thank the organizers. Everyone on the panel. I won't list their names, but thank you for inviting me to this seminar. I'm really impressed by the number of people who are signing up at this hour. It goes to show that for certainty, I think surgical residents definitely work the hardest. Anyway, jokes aside, I think it's a difficult topic to speak about. And as I was preparing my talk, I thought what I would do is to bring everyone through, for the first part, just some of the concepts surrounding radiation, how we think about mucosal radiation, elective mucosal radiation, as you have heard earlier by Professor Shetty, how HPV, the emergence of HPV has shaped the way we think about carcinoma of unknown primary in the head and neck. And then really spend the last part of my talk, or the second part of my talk, focusing on specific scenarios, because that's really where we appreciate a lot of the heterogeneity. And there's really no right or wrong answer, but to expose everyone on the variation approaches and what are some of the considerations underpinning them with reference to the most recent ESCO guidelines. This is my disclosures, nothing relevant to the talk. And as I alluded to, this is the outline of my talk today. For the first part, really elaborating and clarifying the concepts of radiation with regards to total or elective mucosal irradiation, whether we do ipsilateral or bilateral neck irradiation, and briefly, as you can see, whether there's any evidence for concurrent chemoradiation in this disease phenotype. And then spend the second part really talking about the different scenarios. So some background. Now, as you heard earlier, head and neck carcinoma of unknown primary is rare. Well, that being said, we see that there's an emergence, in recent times that could be driven by HPV epidemiology, but by and large, in the grand scheme of head and neck cancers, it constitutes about 5% of all head and neck cancers. But in essence, they actually have a favorable prognosis, and probably more so with the association with HPV positivity. Now, as I mentioned, the treatment pathways are highly heterogeneous within and between institutions. There are really no right or wrong answers, especially with the paucity of high-level evidence guiding total mucosal irradiation versus elective mucosal irradiation versus neck-only irradiation. Now, the arguments for total mucosal and elective mucosal irradiation is that about 25 to 50% of this head and neck CUPs will harbor an occult primary cancer, which will eventually manifest with a gross recurrence in due course. So, of course, depending on the extent of the diagnostic procedures, as you heard earlier, nicely elaborated by Professor Shetty, and I think with the uptake of TORS and more extensive surgery, you might actually find the detection of occult cancers more and more so with the more recent series. But the arguments against total mucosal and elective mucosal radiation, even though it's still widely done, is that, as I'll show you later, the toxicities of radiation, while we argue that with the new techniques they are far less than before, can still be very debilitating, especially in this subgroup of patients who can be very young. Now, of course, everything's about the yin and yang, striking a nice balance. And I will also espouse on some of the ideas behind, can we use intermediate doses as opposed to high radiation doses, and omitting chemotherapy so that we limit toxicities if in the scenarios that we do TMI or EMI, thereby optimizing the therapeutic ratio. Now, just briefly, I'll show you examples again later, but these are some examples of the contouring of total mucosal irradiation. Now, granted, here you'll see that for some of the, like for example, the nasopharynx, the oropharynx, we do treat bilateral mucosal, like the base of tongue. But for the tonsillar pillar, sometimes we only treat the ipsilateral site. But of course, some practices may argue that they treat everything comprehensively, where the entire nasopharynx, oropharynx, mucosal, as well as the Valdea's ring, does get bilateral irradiation. And that obviously, even just by expanding your margins, your borders, for example, like the larynx to the contralateral site, thus increase toxicity. So in a nutshell, this describes total mucosal radiation, where we cover an entire volume from pretty much the roof of the nasopharynx down to the Valdea's ring, and the doses vary between 54 to 60 gray. Whereas the acronym that you see more in recent series, which is EMI, refers to selective irradiation, and that is on the judgment of where you think the occult primary is coming from. Now, briefly, there are some good series, but here I choose two to highlight. The most recent series will be the one by the Royal Marsden Cancer Center, where they essentially pulled two prospective series. And over that, they tend to use this fractionation regime of 65 or 64 in gray in 30 fraction to the high risk clinical target volume, and the 54 gray, a lower dose in 30 fraction to the lower risk clinical target volume. But this is essentially a very small series of 36 patients, which is similar to what we see in most head and neck CUP series. But this, nonetheless, they're prospective. This is a summary of the clinical characteristics, just to pick a few parameters to highlight. Notably, you see that a large proportion of patients are HPV positive. And this is where you will see a lot of the dilemma arises and heterogeneity arises, whereby you have patients with bulky single node, as well as patients with multiple unilateral nodes. And these are where a lot of uncertainty and heterogeneity may arise between physicians on their comfort level of ipsilateral versus bilateral irradiation. And not surprisingly, about 80% involves the upper level neck nodes. This is the radiation use, schema used in the series. And chemotherapy was used in 50% of patients. Now, if you look at the series itself, just judging by the toxicity, here they pulled grade 2 to 4 toxicity as a single bin. And over time, at 2 years, one could argue that only about a fifth of patients do suffer from dryness of the mouth, now, which ranges again from grade 2 to 4. Now, in terms of dysphagia, the ratio is a lot less. The proportions probably looks like less than 10%, which seems very well tolerated. In terms of local control and local regional control, just with comprehensive radiation to 54 gray to the total mucosal and 60 gray to the high-risk region, you get very good control rates. But this is not surprising given that the majority of the cohort is driven by HPV biology. And this is the survival outcome, showing a very promising 80% survival long-term. Now, how does this compare to the other series? This is just a snapshot. I won't go into details here, but if you look at just the numbers, you appreciate that most of the series are limited. And so therefore, they don't really, provide robust evidence to inform on good practice. The chemotherapy proportion usage it varies, and also I'm sure the regimen varies. But in the Master series, as I mentioned, 50% receive chemotherapy. But if you look at some of the series where up to 90% of patients receive chemotherapy, the toxicities can be quite dire. About half of the patients in this series actually develop esophageal stricture, and you will see that dysphagia and laryngeal edemas can be quite debilitating toxicity over time. Now, of course, what about here? I pivot to an Asian series where clearly here things differ, because in this part of the world, we know that NPC is endemic, and this throws another virally associated cancer into the bucket where this NPC can also arise, give us this similar scenario of a head and neck CUP. So this is a Taiwanese series of 46 patients from 2 institutions where they give elective mucosal irradiation. Now, in the interest of time, I can't go into details, but here they essentially considered if there was presence of any hint of an EBV association, or be it EBV staining positivity in the neck node, or a positive EBV serology, or EBV DNA titer, then these patients would be put through a NPC pathway. Now, here, of course, they use induction, but we know that there's some caveats there. But if there's no suspicion of NPC, then patients receive elective mucosal irradiation, and then ipsilateral neck irradiation with or without chemotherapy. Briefly, the level 2 and 3 again are the most common sites, but as you can imagine, the proportion of neck nodes differ between an Asian series and Western series, and this hints that really I think there's some underpinning viral etiology that's associated with head and neck CUP, and we will see that's where there's a discordance in terms of the biology and presentation between patients from Asian series and patients from the Western series. But nonetheless, very promising outcomes, likewise to the Royal Marsden series. Now, caveat here, while the curves may look like it is inferior, but the lower bar here, the axis stops at 60%. So really, I think if you look over time, with the censored ticks going up to beyond 5 years, we are looking at above 80% survival, and certainly very low failure rates of 10 to 20%. Now, this is the radiation schemas used between whether there's a suspicion of NPC versus non-NPC. Notably, I think what you observe here is the high use of induction. And then in terms of toxicity, just briefly, to emphasize on late toxicity that I mentioned, you can see that even long-term, that 30% of patients do complain of some dryness, and about 10% of patients do complain of dysphagia. And this can be quite debilitating in terms of quality of life, despite being low grade for someone who's 40, 50 years old over time. So what did we learn from this small series? That despite its toxicity and the toughness of how to actually for a patient to go through, especially with chemotherapy, TMI and EMI is still widely practiced. I think ultimately it may seem tolerable, but we can't ignore toxicity. And the role of chemotherapy here is really poorly defined, but it's commonly used is based on the extent of nodal burden. Now, here I then bring everyone's attention to some specific scenarios, and I'll bring you through later on with regards to what do we do if they are P16 or EBV positive. Now, how do we then incorporate and rationalize advanced surgical techniques into the extent of volume that we treat, as well as the dose? And I think all this put together really provides for multiple permutations. And without further ado, this is the polling question I raised earlier. I won't go into that, but briefly, it's a young lady with a likely P16 positive or HPV etiology head and neck CUP. Now, what are the considerations in this scenario? Now, of course, we will certainly do the IHCs for all the surrogates for HPV positive oropharynx or HPV positive head and neck squamous cell carcinoma or EBA associated NPC. Now, of course, at this time, we do have to consider what is the surgery we perform. I think this is where, again, I emphasize the point made earlier by Professor Shetty, that it is really a multidisciplinary team approach. That if a surgeon is comfortable and does a lot of TORS or the wider resection, then clearly I think that would actually help us think about our radiation volumes. And I'll show you examples later how this may matter. And of course, whether the presence of other adverse features like extracapsular extension and so forth. Now, there are many permutations, but briefly, just to go straight into what one would do, or at least what I would do. Now, it doesn't mean that it's correct, but I'll show you later how this converges and is aligned with the guidelines put forth by ASCO. Now, of course, in a P16 positive scenario, with TORS being performed, and TORS does not reveal occult cancer in this hypothetical scenario, one could be comfortable to just actually omit total mucosa or elective mucosa radiation in a limited nodal disease. So here I emphasize N1, 2A, and this is based on the 7th edition staging. And if it's truly PN1, I think there's really a role to be conservative, where there's no role for concurrent chemotherapy and potentially patient can be observed. And this is also being highlighted in the ASCO guidelines. Now, of course, it doesn't mean that this should be put forth as the first line standard of care, but it is one option that can be discussed as opposed to radiation to the neck node alone, or even if the patient is risk adverse, elective mucosal irradiation with radiation to the neck node. Now, I'll provide you evidence why we may be able to avoid radiation of the primary bed. Now, what if there are no TORS performed? I think that in this scenario is quite straightforward, where we would just give elective mucosal radiation. We don't actually have to extend the entire mucosal, and then potentially add chemotherapy. Now, in the P16 negative scenario, and if indeed, again, TORS or extensive surgery is performed and does not reveal occult cancer, I think we'll still give chemoradiation to the neck, because we know that this group is certainly belong to the more aggressive biology subgroup. I think the main thing here is that, observation would not be recommended as opposed to the P16 setting. Now, if there's no TORS being performed, of course, treatment will be much more comprehensive, where it entails thorough mucosal irradiation, radiation to the neck, and here I might actually like to treat ipsilateral neck with potentially chemotherapy. Now, as I mentioned earlier, where do we derive the evidence that potentially in patients with good surgery performed in the P16 disease subtype, where we can avoid irradiating the primary bed and thereby sparing patient from toxicity? Because we know that combination treatment of both surgery and then radiation to this raw surgical bed can thus induce incremental toxicity. And this is a very nice study, a prospective single-arm phase 2 study led by my dear colleague, Alessandra Lin from UPenn, where it's called the AVOID trial, where they essentially deliberately avoided radiation to the primary bed. Now, there's a caveat here. While it would seem that in this schema that they avoided radiating the surgical bed outlined here and just targeted the radiation to the neck nodes using proton beam therapy, and they reported very good local regional free survival, so meaning that you can avoid radiating the primary bed without risking recurrence. But the caveat is that the primary bed still receives some radiation dose. It's not zero dose, but much attenuated to 40 gray. So it will suggest that for an extremely sensitive tumor like HPV positive oropharynx squamous cell carcinoma, that a high dose isn't required post-surgery. Now, then here I shift gears to the ASCO guidelines. You've heard earlier by Professor Shetty, but I'll really sort of dwell into the clinical pathways. Now, briefly, this is a multi-stage process. I was a part of this process for another guideline. So essentially how it's done is that it's based on the GLIDES process, and good high quality studies are curated over time. And then the experts first, before extracting the studies, decide what are the key questions for the specific disease scenario. So as you read the guideline, all the different questions are essentially agreed and confirmed by the different experts shown here, represented across the world. And then they will then find evidence that fit for purpose to answer these questions and then develop a pathway. So it's a more active approach as opposed to the generic systematic review. This is the overall schema. And just to pick a few scenarios to elaborate on, here you see that in the definitive surgery setting, and here they loosely define what is meant by definitive surgery. It could be a neck dissection or a tonsillectomy or a TORS. But nonetheless, I think if there are multiple involved nodes, then it's straightforward. But if there is presence of limited isolated disease without aggressive features, potentially layered on with a P16 positivity, it's arguable that these patients could be observed. Now, what about in the more definitive scenario or the more aggressive setting? So in patients where it is agreed that they'll be treated with definitive radiotherapy, and if they are HPV-related adenopathy, the difference between that and the HPV-negative disease is the coverage of the mucosal. So as you can see here, they'll say that if it's a limited nodal disease that is HPV-related, then one may safely deliver radiation or elective mucosal radiation to the ipsilateral oropharyngeal mucosa, thus sparing toxicity. Now, of course, if there's bilateral nodal disease, then it would entail treatment of the bilateral oropharyngeal mucosal. Now, a caveat to Rachel mentioned here is that if there's bilateral disease or high volume disease, then of course, definitive radiotherapy should be offered up front. But there are scenarios whereby even if it's bilateral or multiple small volume disease, and if the volume is not large, then potentially surgery can be considered. Now, the other part to emphasize here is that they also dwell into specific scenarios. For example, like if there's suspicion of a nasopharyngeal primary, then that itself will be sufficient. Whether there's multiple or unilateral nodes, and I wouldn't go into details here, but definitely I would sort of encourage the residents to read the paper in detail, because it's a really nice dense paper comprising of 16 to 20 clinical questions relating to the different scenarios, and they will offer their recommendation along with a short excerpt on why the recommendation was made. And intuitively, of course, if there's bilateral disease, I think just the point to mention here is that well, in the past, we just treat this patient definitively with chemoradiation, and that remains to be the case or the preferred approach. I think that in patients with small volume disease and where there is high level of surgical expertise, in the presence of an NDT setting, I think definitive surgery can be considered upfront, and potentially that can be used to stratify patients more accurately and perhaps encourage a de-escalation approach. So this would be the scenarios that I mentioned here. Now, finally, in the last couple of minutes of my talk, I would just like to sort of showcase some where we are now with regards to radiotherapy techniques. And despite advanced IMRT, VMAT, which stands for volumetric arc therapy, which really allows for quite steep dose gradients from high to low dose, and then of course proton therapy, where are we now in terms of transitioning the techniques, limiting those splashes, and then trying to limit toxicities. So this is an example of a patient of mine. She's an opera singer, presented with a neck lump about 4 centimeters in size. And of course, if you see here, looking at the neck cytology, it is suspicious for HPV biology. Now, at the time when I saw her, there was very little data from AVOID, from all the de-escalation studies. So in summary, she went through a neck dissection, pretty bulky node, no ECE, 1 out of 30 nodes positive, but that shows P16 strong positivity. Now, what will we do, right? Considering that she's young, she's anxious, she's also risk adverse, but she then obviously her voice quality is important for her job. But the tumor board then decided that we would offer chemoradiation, and this was the radiation fuel that was given. Now, of course, the caveat here was that I treated this patient a few years back, And if given the opportunity again, I probably would have limited my radiation field a lot smaller. But you can see here in both the axial cut and the coronal cut, using just the 50 gray dose to the elective, to the mucosal, to the total mucosal, we treated comprehensively from the nasopharynx all the way down to the Valdes ring. Now, I would say that at the time, why I was probably a bit, overzealous was that we know that P16 positivity means nothing. That, a lot of times we can still get HPV positive hypopharyngeal tumors, nasopharyngeal tumors. And so, I was just being, probably more risk adverse than the patient herself. And this is at least what we did at the time was try to limit the low dose splash from the oral cavity, so limiting the ulcers and all that. And we look at the 30 gray, it means even lower dose splash. While I was able to sort of shave a very nice clean line away from the oral cavity, you can see that, when we get to lower doses, that's really a lot of splashes to the occiput away from the cord. And then obviously you get this dose splash to the oral cavity. And we know that the taste buds are extremely sensitive to radiation. And so the squeeze here will be a pertinent side effect. Now with proton therapy, of course, you can save the low dose splash. But nonetheless, if you just look at this small series from the Anderson group, if you look at it over time by the grades of xerostomia, if you just look at grade 2 and 3, you still get in a 15-patient series, a good number of patients will still suffer from debilitating toxicity despite, proton beam therapy. So I think, we have a long way to go. I think in this space, it's really about understanding the biology. And if we do it well, then, I think that's where we'll really push the needle in terms of, better streamlining of treatment and potentially better quality of life. And so with that, I think to end my talk, I choose to do, the uses of my last slide here because it really brings back memories about all the different times I have, we miss coming together. And this is really where, friendships are forged, research ideas are born, and, productive collaborations occur for the betterment of mankind. I hope to do that soon in due course. And you will recognize some of the faces here. And with that, thank you for your attention. This is the new National Cancer Center in Singapore. When travel permits, I welcome all of you to visit. It will have the state-of-the-art proton beam therapy and so forth. And thank you again for your time, and happy to take any questions.
Thank you very much, Professor Melvin Chua. Exciting, very informative talk, especially when you mentioned a young 50 years old. So put a lot of us very happy tonight. So thank you for that. So
it's important to feel youthful. Yeah.
So there's a lot of questions already been answered also by Professor Shetty. We'll try to cover that verbally as well if you have time. So now we move to the panelists, to the panel session. And we have 3 panelists. I would like to introduce all 3 of them. First, we have Dr. Thanuja, Dr. Thanuja Mahaletchumy. She's from our hospital from Malaysia. She's a consultant nuclear medicine physician. She's the head of Department of Molecular Imaging and Nuclear Medicine at the University Kebangsaan Medical Center. We have the second panelist, Dr. Napadon, Tangjaturonrasme. He is a head of a head-and-neck surgery division, Department of Otolaryngology, Faculty of Medicine, Chulalongkorn University, Thailand. And he also a secretary of Thai Society of Head-and-Neck Oncology. And we have a third panelist, Professor Christy Joy Arquiza. She is a clinical as a professor at the University of Philippines College of Medicine and Board of Trustee, Philippines Academy of ORL Head&Neck. So to start ball rolling, I would like to invite Dr. Thanuja to give her input on Occult primary investigation. The floor is yours, Dr. Thanuja. Yeah.
Thank you very much, Professor Razif, for the kind introduction. Thank you, Professor Shetty, and also Professor Melvin for their very concise and interesting lectures. It has been very informative to be briefed on all these latest advancements in managing head and neck cancers, particularly for someone like me, who's not particularly from the head and neck team. Okay, As I'm from the field of nuclear imaging, I would like to share my own experience and a little bit of information maybe in relation to FDG PET-CT, in addition to what Professor Shetty has mentioned earlier in his slides. Okay, I think we are all aware most guidelines currently actually advocate the use of FDG PET-CT only if a contrast-enhanced CT fails to detect the unknown primary. I think this is owing to a few factors. One mainly because of the non-availability of FDG PET-CT in a lot of centers. So as a first line, contrast-enhanced CT is usually performed. Okay, but based on my own experience from my center, as well as from literature review, it is quite evident that FDG PET-CT is actually more superior in detection of these subclinical tumors. Okay, because of a higher sensitivity and specificity in comparison to a contrast-enhanced CT alone. Okay, this is mainly because of the technical advancements in the PET-CT scanners itself. I think if you look at the literature previously, like many years back, definitely the detection rate of these unknown primaries was much lower. But later studies have actually revealed much better detection rates, okay, because of all these advancements in the PET-CT scanners itself. The resolution of the PET component is very good currently. And the CT component of these PET-CT scanners, they are of a highly diagnostic quality, okay, equal to the standalone CT scans. Therefore, as Dr. Shetty mentioned earlier, if this modality is available, it would be actually ideal to perform it as the first line cross-sectional imaging, because it not only shows off the morphological changes, it actually shows the metabolic changes, which actually happens much earlier than the morphological changes in these tumor regions. Okay, and the diagnostic value of this FDG PET-CT is always added much further if it's actually coupled with a contrast-enhanced CT, meaning the PET-CT is performed together with a contrast enhancement. Okay, but we have to keep in mind of all the false positive findings in relation to FDG PET-CT, particularly in the head and neck region. Physiological uptake in certain areas of the head and neck tend to be quite high. So small volume lesions can go undetected, can be masked by this high FDG uptake. Okay, and even inflammatory processes, coexisting infections, all these can actually give rise to false positive findings. Okay, but one way to actually reduce these false positive findings in patients with unknown primaries, which is more related to the inflammatory process, would be to actually perform FDG PET-CT prior to the diagnostic workup, sorry, not prior to the diagnostic workup, prior to the guided biopsy. Because if a FDG PET-CT is performed after the biopsy, then the area of the biopsy actually will have a bit of inflammation going on, so there'll be high FDG uptake there. So if there is a tumor, especially if it's a small volume tumor adjacent to the site of biopsy or within the vicinity, sometimes it can go undetected. Okay. And not only that, the benefit of FDG PET-CT, yes, one thing, it can assist in detection of the unknown primary, but upon detection of an unknown primary tumor, okay, when it actually, when it's able to detect a primary tumor, it can subsequently serve multiple purposes. One of it would be to assist in the radiotherapy planning, if it's the treatment option for this identified primary tumor. At the same time, because it's a whole body imaging, it can also show the metastatic lesions, okay, elsewhere in the body. And if there is a second primary cancer, which is not from the head and neck region, okay, it's also useful in that sense. And in these patients, subsequently, this modality can be used to assess other things such as treatment response or even disease monitoring, okay, particularly if there is a need to differentiate a recurrence from a post-treatment related changes, because sometimes the metabolic changes occur faster than the morphological changes. Okay, so it can be beneficial in multiple ways. But having said that, of course, in my opinion, and I think for those who are managing head and neck cancers, they would agree with me that performing FDG PET-CT will be useful as the first-line cross-sectional imaging wherever it's available. Thank you.
Thank you, Dr. Thanuja. You're actually part of the head team. Very important.
Okay.
So thank you very much. I'm sure there will be a question later on to you. So
okay, sure.
now, yeah. So I would like now to invite my friend Dr. Napadon to give some input.
Thank you, Professor Razif. In my point of view about the carcinoma of unknown primary, normally myself, I have a 3-step-wise approach to this situation. The first thing I need to do is to perform and to confirm the histological diagnosis about the cervical lymph node enlargement. This is quite common pitfall, and sometimes it's confusing from the general practitioner to approach every patient with the neck lump and or neck mass and manage them as a carcinoma of unknown primary without histological confirmation, which is not wrong, not right, it's incorrect. The second step is to perform the primary site and survey for the distant metastasis. For myself, I use the histology, H&E or the immunohistochemistry. I use the location of the lymph node. I use the incident or the epidemiological data. It depends on your practice that which tumor is common. And finally, I will consider the treatment options. About the real life situation in Thailand, we have quite common the nasopharyngeal carcinoma. So the test about the EBER that to identify the EBV is quite useful. Normally we combine with the blood testing for the EBV viral load. And as you know that the nasopharynx common presented with the submucosal infiltration, so we cannot find any suspicious within the scope. And I would like to mention about the benefit of the P16 staining in the neck mass. In here, in the South Asia, I think the incidence of the HPV related is quite low. So the correlation with the P16 staining and the HPV oropharyngeal carcinoma is maybe discordant. So we need to approach with caution. And if you want to confirm, you need to check with the another test that prove the HPV was presented in the next specimen. And the last comment, I would like to remind all of you that everybody have a very good tool to perform the detection of the primary is your finger. Don't forget to perform the palpation. I'm totally agree with Professor Shetty. Palpation, the buccal mucosa, oral tongue, floor of mouth, oropharynx, looking for the submucosal mass and looking for the area that easily bleeding. It will help you and leading you to find the primary. Thank you.
Thank you very much, Dr. Napadon. Very nice sum up of the talk. Now I would like to invite Professor Christy Joy. Arquiza.
Thank you, Professor Razif. And I'd like to congratulate the Head&Neck Network on episode 10. So I remember the very first episode. It was one of the earliest webinars during the start of the pandemic. So we've spoken about a lot of things since then. I'd like to start with the limited experience we have here in the Philippines with occult primary in the hospitals in which I practice. I checked with our chief resident in 2019. We only had one admission for cancer of unknown primary for panendoscopy under anesthesia. No, so why is that? No, we're actually a high volume cancer center, and we only had one admission for the whole year. So this might be related to a low incidence of oropharyngeal squamous cell carcinoma here in the Philippines. As Professor Shetty emphasized, majority of occult primaries in the head and neck may turn out to be oropharyngeal. Some studies note this up to 90% may oropharyngeal squamous cell carcinoma. Here in the Philippines, the incidence is only 0.3 of all cancers. So it's not very common here. And if you look at the HPV-associated oropharyngeal squamous cell carcinoma, that's even more rare because we still have a high incidence of heavy smoking in the population. So our incidence of smoking-related squamous cell carcinomas are still pretty high as well. Okay, so that's the first one. The second, it could also be related to better use of high definition flexible laryngoscopes in the office rather than going straight to the endoscopies, going straight to the operating room for the examination under anesthesia. No, so I find it very interesting that our search for the primary is actually the opposite of how we plan our elective neck dissections. No? So if we have level 1 nodes, we look more closely at the oral cavity, and it's really important to palpate all of those and to examine it very well, no? And our scopes help us with that. No? So if we have level 2 nodes, we look more carefully at the oropharynx. That's a little bit harder to palpate, and that's when examination under anesthesia is more important. And if you have level 3 and 4 nodes, you look more at your larynx and your hypopharynx, no? And I think that's the analysis also which will guide elective mucosal irradiation by our radiation oncologists. No, so I found that very interesting, that information can work in reverse as well. These small incidents may also be related to better imaging. I do agree with Dr. Thanuja that an FDG PET may be more useful upfront. In my setting, we're actually very careful about use of resources because I work in a public hospital. But in terms of cost effectiveness, having a CT for multiple sites versus PET CT, which is with the addition of the CT, is very accurate. Sometimes it's better to go straight for the FDG, and I've seen a lot of my colleagues do that, go straight for the FDG PET. And I admit that I do that as well. Okay. And then another one would be better use of immunohistochemical stains. No? Before our fine needle, we would only get maybe squamous cell carcinoma, but with the use of, with the search for HPV and EBV, that gives us clues on where the primary sites will be. No? So if it's HPV, more of an oropharyngeal problem, and EBV, more of a nasopharyngeal problem. Similar to Thailand, we also have a high incidence of nasopharyngeal carcinoma here, no? But most of that we do discover on even on flexible laryngoscopies or flexible endoscopies, so they don't count. They will not be counted as cancer of occult primaries anymore. Okay. I also wanted to to emphasize the ASCO motto there. Knowledge conquers cancer. So I'm so happy that there are so many people who are interested in beating cancer right now and getting more knowledge so that we can all together conquer cancer. Thank you.
Thank you very much, Professor Christy Joy. So that concludes the panelist session. We have a lot more to go, especially the exciting part of question and answers. But before that, can we have back the poll, the pre-lecture poll, so we can see what is the results like? Okay, so let's see the first question. Any of the speakers want to comment on this?
I will do that.
Thank you, Prof. Yeah.
And also Dr. Thanuja has explained beautifully the use of PET scans. As all the three panelists mentioned, the contrast enhanced CT scan is very easily available, very affordable, and very reproducible. And Dr. Christy mentioned that even though she asked for a PET scan, but we all are aware of resource constraints. So, contrast enhanced CT scan still is the initial investigation. However, for all the reasons Dr. Thanuja mentioned, PET CT becomes a preferred investigation of choice in identifying unknown primary. Now, PET CTs especially have got a false negative rates and a false positive rates, which already enumerated by Dr. Thanuja. It depends on the standard of practice or guidelines you follow and the resources you have. and economy of the patients as well. Because healthcare is free, healthcare is free, and our public hospitals do have PET scans. We could get PET scans. It is not true that rest of the world should follow the same thing. I still feel CT is the initial choice, and PET if the resource available. And there was some questions on MRI, contrast enhanced MRI. It has a role to assess the volume or primary extension of the primary oropharyngeal region, skull base, lingual angle, as well as perineural spread. It has got a role, and the radiation therapist usually gets a planning MRI. Sometimes you have a bulky disease, but we are talking about unknown primary here, so we should stick to the topic. Ultrasound is not an initial assessment, but ultrasound is helpful in targeting your needle in the node, if the node is small or cystic. Sometimes what we do is we remove the cystic component partially via ultrasound guidance and target the viable aspect of the cyst or a cyst wall for some cellular material, because most of the basaloid neoplasms or HPV tumors have got cystic metastasis, and they have cyst-forming metastasis. By saying that, papillary thyroid carcinoma, melanoma, and nasopharyngeal carcinoma, all these also can produce cystic metastasis, but mainly currently in level 2, if there is a cystic metastasis and you want to rule out HPV related, you need to get a viable cells. So with that, ultrasound goes out, MRI goes out, contrast enhanced CT and a PET CT, as the general poll says here, 77% favors the FDG PET CT, and I also favor it because it's available. If it is not available, I would go for a CT of the head and neck and chest. Actually, I should include the chest in the answer, because chest CT is a very sensitive and specific investigation for lung mets as well. Thank you.
Thank you very much, Professor Shetty. I would like to direct a question to Dr. Thanuja about this question as well. Because sometimes when we perform a PET scan, there is also light up a few places, especially at tonsil, and you do have bilateral. So how do you guide, whether this is a primary tumor or in fact possible inflammation?
Yeah, this is where the false positive issue comes in actually, because tonsils is an area where there's frequent infection, even tonsillitis. So we tend to look at certain criteria, such as symmetry would be the first one. Things like tonsillitis, there tend to be a symmetrical uptake in most cases. Secondly, of course, we also look at the morphological aspect a little bit, whether the outline of these tonsils appear normal or they're swollen, enlarged. So these are the few things. Otherwise, there's nothing else much can guide us to whether it's a true primary or it's a false positive finding. And it's not only tonsil, there are a few other areas, even the places like base of tongue and all that. If the patient during the waiting period for the scan, upon injection of the FDG, if they're actually moving their tongue about, either talking or doing something, it can also have very high uptake. So small lesions will actually go missed.
Sure. Sure. Thank you very much. Now we go to the next question. Right. If Prof. Melvin Chua is here, can you comment on this? Yeah, okay, let me see. Or anyone else want to comment on the second question? Prof. Christine, what do you think? Do you agree
Could
that?
we have the second question?
Sorry, what was that?
Could we be shown the second question?
Yeah, can we show the question? Yeah, you can scroll up. 45-year-old lady. Can you see that, Prof. Christine?
Yes, thank you. Non-smoker. Okay. Well, this would make me suspect that it's there be an oropharyngeal primary non-smoker, female, well, smoker, more likely to have that HPV association, and lymph node on level 2, small equivalent lymph nodes, but very low SUV, FNA, squamous cell carcinoma, random C, even though at ND base of tongue tonsil, so benign. Okay. Yeah, so I think the charts are pretty well distributed. As a surgeon, I'm more inclined to do some form of surgery.
Yeah.
I definitely do not transoral robotic surgery for now, but I've noticed there are good reports about good reviews about its efficacy, so functional outcomes and ipsilateral. Yeah, so that is my bias. Having a surgical specimen also helps with margins, and also might contribute to a more definitive histopathologic diagnosis as well. So that's the advantages of the surgery. Histopathologic diagnosis and determination of margins, which will all help with staging and which will all help with determination if you need to add chemotherapy concurrently to your radiation therapy. But it is the surgery. That also, you have a limited, it's only 1.5 centimeters.
Yep.
So yeah, single modality will be enough for this case.
Yeah, sure. Thank you very much, Prof. Christine. Anybody else want to give comment?
Dr. Razif, Professor, can I comment on?
Yes, please, sir. Yes, please.
I entirely agree with Dr. Christine on her comments on this. In this patient, it's a 45-year-old lady. She's very young and a non-smoker, so it's a low risk to intermediate risk disease. And it's a basaloid features, P16 positive probably, and it's a HPV-related oropharyngeal cancer. Now, there are multiple levels of the nodes involved, that is level 2 and 3 and 4. And I do not agree with the modified radical neck dissection for this. We can do a selective neck dissection with the less neck dissection associated complications. As you know, level 4 dissection always, if you're clearing a lot of that, nodes can lead to chylus disease, chylus leak, spinal accessory nerve injury, hypoglossal nerve injury, and vagal injury, and also neck dissection related impairment and quality of life issues. So we can reduce that with selective neck. And TORS, this is very interesting concept because TORS is not widely available at all, actually. What we do when there is no robot, we can use a 3D endoscope with the usual Crowe-Davis mouth gag or FK retractor, and we can do ipsilateral tonsillectomy, tongue-based mucosectomy ipsilaterally in this patient, as good as a TORS. But TORS is very useful when you go and do a tongue-based resection because of its maneuverability and angled views. However, I've done quite a few endoscopic oropharyngectomy it's very good, but when it goes to mucosectomy, you struggle a bit. It depends on the patient's mouth and opening and other factors, but still you can accomplish the mucosectomy. But these things, mucosectomy and tonsils, should be submitted for frozen to look at whether you got a margin positive or negative. As it says, there is no mucosal uptake. That means you're dealing with a very small primary here. The primary is so small, maybe 2 millimeter to 4 millimeter or 5 millimeter. That's the cutoff for PET scan. That's why it did not identify a primary. That's why the less sensitivity comes in. So I would do that and get a frozen section. And if there is a good margin around it, I finish there and subsequently discuss the histology and the neck dissection in a multidisciplinary setting, and then take advice from our colleagues, radiation and chemotherapy colleagues. Histological features are ECE or extranodal extension really, or a positive margin really pushes me to the trying 3 modalities. We should avoid 3 modalities by any extent in carcinoma non-primary, because 3 modalities is 3 times damage to the patient. So you need to really look into 2 modalities or possibly 1 modality. You have done a neck dissection, no ECE, and your primary is completely excised. You could observe as well, but here there are multi-level nodes are there. So it could be N2, and as the number goes, all the nodes lead to recurrence. So it's a good idea to have a discussion with radiation oncologists, as well as get a PET CT at 3 months after your initial managed surgical or radiation management. That will guide you further, because most of the recurrence or residual activities can be, or treatment responsiveness can be seen by 3-month PET CT. Thank you.
Thank you very much for your comment. We have another one question here. This is a thought-provoking question. Anybody can comment on just doing a neck dissection for CUP, and we do a PET scan every 6 months until the primary showed up. I find this quite interesting concept. So maybe Dr. Napadon, do you have any thought on this?
I think it's possible if the neck volume is quite small, maybe only the N1, and did not show up any clues in the primary. That's mean the no EBV, no any suspicious of the HPV related carcinoma, and you need to discuss with the patient very carefully that they need to come to have a regular follow-ups. But I still think that the PET every 6 months is use a lot of resource. Even in the big centers, it's very difficult to do that. So I think if the first time PET is negative and the node volume is small, and I do everything, including the tonsillectomy, and it's not show up any primary, the neck dissection review, everything is safe, small, no risk features, I can follow up. But I may follow up with the physical examination and maybe another imaging modality.
So Dr. Thanuja, the question to you, are you happy doing a 6-monthly PET scan?
Whether happy or not to read the PET scan, yeah, I'll be happy to read the PET scan, but then it goes back to what has been discussed previously, whether, on the resources side, and whether it's going to add any benefit or not. If patient present again with some symptoms and, we think, that there might be another lesion that can be detected, yes, I mean.
Patient might ask about the risk of having a frequent PET. Any
yes, true, because there's a radiation concern there, because when we talk about PET CT, we have 2 types of radiation exposure there. CT is just the CT radiation alone, but with PET we are injecting with the radioisotope, which itself carries some radiation. But all these, the doses are very much below what's actually can cause any deterioration to the patient. But then again, if it's a young patient and if we plan to do a repeat PET CT every 6 months and so, it's not really a ideal management plan. Yes.
Thank you. Thank you. We may have one or two more questions. There's always question about bilaterality of tonsil. Some center do only one side, some center do both sides. So if I may ask again, Dr. Napadon, what is your practice?
Yes, I think for the tonsillectomy and the non-primary, myself, I did the bilateral tonsillectomy because of many papers show up that they have a chance about 10% that come from the another side, and that's, I think that's true because I found it myself 2 cases. The tumor come from contralateral tonsil, and you do the bilateral tonsillectomy. When you follow up the patient, we will get more easier to see the tonsillar fossa that's smooth and symmetrical. That's for me, for myself, I prefer to do the bilateral.
Thank you. Professor Christine Joy, what do you think? Can you hear us?
Yes, I agree with that. I would do bilateral tonsillectomy because there is a significant percentage in the contralateral tonsil. Acidity when you do that is also not very high. Do your tonsillectomies properly and safely. And for monitoring afterwards, I do having bilateral. The system is much better and it's easier to evaluate for any recurrence or any new lesions.
Thank you. Professor Shetty.
Yeah, I think bilateral tonsillectomy is a very wise approach. Not only Dr. Napadon says he can follow up the patient better, his PET scans are symmetrical, his examination shows quite nice healed tonsillar fossa, so he's happy. But it's like HPV is like smoking. It has got a field cancerization effect. There is a local recurrence chances. There is a contralateral tonsil recurrence chances. And also there is a distant metastatic chances, because HPV is, even though de-escalate and everything, it's not benign anymore. It's a cancer. So I would think bilateral tonsillectomy is a very wise approach, but there is a small risk, but even though it is very small, it is not zero. So the patient should be told, if you're doing a bilateral tonsillectomy to a patient, he may not go ahead with a stepped neck dissection because of the pain, because every one of us have got different pain thresholds. One of my patients said no for neck dissection just because he had a poor pain control and poor pain threshold for bilateral tonsillectomy. So that has to be explained to the patient. I think patient-centered decision is a must when you're doing this.
Thank you. Thank you. I think I just had another question, so maybe last question. You're talking about mucosectomy, tongue-based mucosectomy. It's actually easy to do with, it's relatively easy to do with robots. But anybody here have an experience of doing tongue-based mucosectomy just by doing an endoscope, and how deep that you want to go to clear that tongue-based mucosa? Anybody have an input on this? Dr. Napadon, have you had, you want to give any comment on this?
I normally did not use the endoscope for the tongue base because of it very quite difficult, and you cannot see the angle and you cannot control your instrument really well. Usually if you want to do the mucosectomy with the robot, I think maybe half centimeters or not over centimeter is enough, because of the tumor usually not going deep. But it's I'm not doing much about this.
Thank you. Thank you. Professor Shetty, you want to share anything on the tongue-based mucosectomy? Please unmute yourself, sir.
I was reading some interesting questions. There are some amazing questions are on the question pool. Unfortunately, we cannot answer everything. Your issue was lingual mucosectomy. Lingual mucosectomy is quite easy to do when you have a very good access. How I do it is generous view of the base of the tongue and using a 3D endoscope, making an anterior cut and a medial cut and defining where you want to cut, and go with the mucus. And as a base is the lingual muscles or extrinsic muscles of the tongue. So you take only the mucosa out. Now, the very important aspect is pinning it and identifying all the correct edge and giving it to pathologists yourself with the picture of the tongue base, and where is the anterior margin, where is the medial margin, where is the lateral margin, where is the posterior margin. Very important aspect of our care is to pinning it and identifying it, all the edges, all the margins. Because if you have a tumor and you are bisected the tumor at the edge of the anterior margin, you can come back and resect further. So it's very important for us to identify these things for the pathologists. Otherwise, it is a simple procedure. Only thing is, when it goes to too much lateral at the tonsillolingual sulcus, there is a chance that a lingual artery you can hit. But if you are with the 3D endoscope very close, you could clip the arterial branches as you go further. And a monopolar cautery is the preferred one for me. And somebody asked me, coblation I use. I don't use coblation. Coblation just dissolves the tissue rather than cuts the tissue. So I use monopolar cautery in a low setting. And also I let my anesthetist know I'm using a monopolar in that area, so he can keep the FiO2 below 30. Thank you.
Thank you very much, Professor Shetty. Bear with us, we've got a few more sessions in this program, but I would like to wrap up this Occult primary discussion. So, ladies and gentlemen, it has been a very informative and very interactive session. We hope that we learn from each other. Not you learn from us, but we also learn from you. And I think one of the message that we can bring back today is that managing occult primary, it really depends on the availability of the instruments, of the treatment in your center. Of course, we would like to have the best of robotic surgery, of a PET scan, but sometimes it's not available in some center. But you still can manage occult primary if you go by principle, and as mentioned by Prof. Shetty and other Dr. Napadon, as simple as palpating the tongue base, palpating the tonsil, we can detect the primary. So before we go further to the next session, we would like everyone to scan the code, so the evaluation code. And please answer the questions. This is very important for us to see the feedback and improve in our next webinar. Okay, right. So please scan the evaluation form. Okay, so we are going to the video now, to the probably the exciting part of this. As we know, as we mentioned, that we always end up with a song, and it's going to be this time a song from Malaysia, Sungai Lui. I just read a bit what does it mean. In fact, this is a song made popular by one of our singer in Malaysia, and it's about the place lived by the indigenous people in Malaysia. The lyrics tell us about the modern development in the rural untouched nature, and it gives message that love the nature despite modern development. So ladies and gentlemen, please enjoy the song by our head and neck team.
Pejamkan matamu untukku, dengarlah dia berkata-kata. Usah kau ragu, di sini tempatmu, walau berubah di mata kita tetap indah selagi kau masih percaya.
Tertawa sekewa terpisah, jalan yang lurus sekian berhalang. Adakah semua yang ku inginkan, ataupun hanya mengejarnya semata-mata, ku harap masih percaya. Adakah semua ini yang ku inginkan, ataupun hanya mengejarnya semata-mata, ku harap kau masih percaya. Kita bersama, masih muda, masih merah, ku harap kau masih percaya. Selama
Thank you very much, especially to my counterparts from Philippines, from Indonesia, from Thailand, from Singapore, and also from Malaysia for singing that song. So, ladies and gentlemen, it's been a great pleasure this evening. So, I would like to pass the session to Professor Alfredo Pontejos. He's a professor and former chairman of the Department of ORL in the University of Philippines, and also a past president of Asian Society of Head and Neck Oncology. So, it's a great pleasure to pass to you, Prof. Alfredo.
Thank you very much, Razif. As always, this has been a very highly informative and educational webinar. Thanks to Professor Shetty, Professor Melvin Chua, Professor Napadon, Professor Thanuja, and Professor Arquiza. The next webinar will be in November, and this is in conjunction with the Korean Thai Society Head&Neck Oncology meeting. And the topic will be controversies in the management of head and neck cancer. I hope all of you can join us again in November. And well, there will be no photo because of certain constraints. There will be no group photo because of certain constraints with the Zoom meeting. And so we would like to end this webinar, and we would like to thank all for attending. Stay safe, and God bless us all. Thank you very much, and good night.
Right. Thank you.
Thank you.
Bye.